A very warm welcome to everyone. Thank you for joining us after your busy day. I am Dr. Sakshi Lalwani. I am practicing pediatric and neuro-ophthalmologist in Mumbai at our Bandra branch. I wholeheartedly welcome everybody around. And today we are looking to have a very meaningful, extremely insightful discussion on some neuro-ophthalmology. How do you approach them, the cases? It is my pleasure to introduce my fellow colleague, Dr. Asmita Mahajan, who is a practicing pediatric and a neuro-ophthalmologist. She has completed her post-graduation, her senior residency from RP Center, AIMS, New Delhi. She also has served as a faculty instructor at various international platforms, like we have the Asia Pacific Society, South Asian Society, as well as our All India Ophthalmology Society. She has also contributed to myopia control guidelines as a part of our AIOS instructor courses. And to her name, she has numerous publications, also multiple prizes from various presentations from our Indian Neuro-ophthalmology Society. Welcome, Dr. Asmita. She will be giving us an idea as in how can we approach and manage neuro-ophthalmology cases in general ophthalmology practice.
Good evening. Thank you, Dr. Sakshi, for the warm welcome. I thought a lot about how to go about summarizing neuro-ophthalmology, which I personally feel even now I'm still learning in about a 25-minute talk. Let's go through some things that I think will really help you in a general ophthalmology practice, because a lot of these patients can be managed by you in your general OPD. Let's start with the very basic. First patient which really boggles our mind when they walk into our OPD is a patient with headache. Because when you talk about headache, you can talk about something very basic as a refractive error and going all the way up to a brain tumor. How do you approach a patient who's walked in with a headache? So we'll go step by step how to approach them. First is obviously the history. Duration is very, very important. A 1 day, 2 day headache, obviously you can take very lightly, but 1 or 2 weeks headache, yes, then you start investigating. Sometimes patients will give you a very nice clue in the history itself that once they change their glasses, since then they're having that headache. That also gives you a clue that something might be wrong with the glasses. And if the headache has been going on for 2 to 3 months, definitely that needs your attention. Then the second question you should ask them is, what time of the day is the headache? Because when we are talking about refractive errors or digital eye strain or convergence insufficiency, then definitely it cannot be a early morning get up from the morning and have a headache kind of situation. It will definitely start when the patient has been in their working hours for about 4 hours, and around 12:31 is when the headache will start. Then you think of probably it could be a convergence insufficiency or the refractive error, or today very, very common you see a cases of digital eye strain, which initially used to be called a computer vision syndrome. Then the third clue that you'll get is from the pattern of headache. Some patients will classically tell you that along with the headache, I have a little bit of sound sensitivity, light sensitivity, and sometimes they even end up with nausea and vomiting along with it. Now, that is also giving you a clue that this might be just a patient of migraine who's presented into your OPD and doesn't really need much of ophthalmological intervention. After going through the history, when you start examining, first, obviously, you go for the visual acuity and the near vision, but when you do refraction, a patient with headache, even if they are like 22, 23, there can be a chance that they have an underlying hidden refractive error. There have been times when patient has walked into my OPD 6/6 vision, but when I've dilated them, they came with +3, 3.5 kind of latent hyperopia. Now, these patients will need glasses. So when you call them the next day for a PMT, try to see if the patient feels a little bit more comfortable when they give +0.5 or +1 kind of power. So basically, they have been having a latent hyperopia and they have been using accommodation and now are presenting with accommodation fatigue. So these patients usually benefit with some small amount of hyperopic refractive correction. Then very frequently we skip on the near point of accommodation and the near point of convergence. So once you check for that, these can also be a contributor for headache, because convergence insufficiency is also on the rise because of excessive use of digital screens. And near point of accommodation, if that is receded, that can happen, then you will need treatment with something called as flippers to treat their accommodation issues. Then secondly, next you will go on to the examination of the pupils. Any optic nerve pathology, you will definitely be able to see a pupillary response changes. Then go for a cover and cover test, look at the extraocular movements, and lastly finish off by looking at the fundus. In the fundus, if you feel disc edema is there you found your cause of your headaches. And if a lot of these times we look at the fundus and we are really confused, like is there a disc edema or not? Is there a pallor or not? If that is the situation, you just go ahead with the imaging where you go for a perimetry, and sometimes even the very subtle changes, their OCT disc with macular GCC has come in handy. You find a small amount of pallor in one quadrant, and then you go for the OCT disc, and then you see that there is an NRR loss or an RNFL loss. You know, yes, there has been a fiber loss that has been, going on underneath. So now we'll go through some cases where these small points have helped me pick up the diagnosis in the patients. So yeah, first before that, yeah, just wanted to say which are the red flags which you think that now definitely I need to refer to a neuro-ophthalmologist. If along with the headache, the patient has some loss of vision, some double vision, definitely you need to refer. If there is some optic nerve head swelling or there is an unexplained disc pallor, definitely you need to refer. If the age is more than 60 and the patient has a chronic headache, definitely cannot be taken lightly, because these are not the patients who will have refractive error, convergence insufficiency, those kind of conditions. Something more serious is definitely going on when a 60-year-old patient says that he's been having a chronic headache. And of course, if the patient is saying some visual field changes, perimetry is must. And I will go through some examples where I'll tell you how exactly it became so important in my patient. The next question everyone has in their mind is, should I order neuroimaging or not? Whenever I have a patient of headache, some eye symptoms, should I order a neuroimaging? The answer for that is very simple. If you have a provisional diagnosis is mine, that is the only time you should be ordering neuroimaging, because it has been so many times that you send for a neuroimaging and it comes back normal. And when we really look at it, there are some small changes that the radiologist has missed. And the only reason for that is we've not told them what to look for. Even the radiologists need to be told what exactly we are looking for. So it's better to have a provisional diagnosis in mind before you order a neuroimaging. Let's start with the cases. So there was a teenage female who came with headache for a few months. She had an underlying refractive error, so I gave her glasses and I sent her off. 2 to 3 months later, she presents with sudden onset doubling of vision. Now she is 14 or 15. I'm not thinking of very serious diagnosis, but yes, definitely I can see that there is an esotropia. It was a concomitant esotropia. I was not even thinking of sixth nerve palsy, acute onset concomitant esotropia. But yes, doubling of vision, red flag, I need to evaluate this patient. Looking at the fundus, you can see, yes, definitely she has a disc edema. And when the neuroimaging was done, you can see the dilated tortuous nerve. She was a case of IAH, idiopathic intracranial hypertension, and had to be managed with Diamox. And after that, obviously, after 3 to 4 months of treatment, she's now doing perfectly fine. Second patient, 35-year-old male with headache for a few weeks, managed with over-the-counter painkillers. He was attributing it to work stress, but he just wanted to know if the prescription of his glasses had changed. Again, following my old protocol, everything was checked, but on the last step, I felt the disc margins were not absolutely clear. Like something was blurry about the disc margins in both the eyes. And again, like we said in our list, if we have a disc edema, definitely that is a red flag, and that patient needed to be evaluated. And to my surprise, not only did he have a raised ICP, very interestingly, half of his venous system was not even patent. It was completely blocked on one of the sides. And when you look at the sagittal sinus, there's actually a blood clot in the posterior part of the sagittal sinus. So this was a patient who had cerebral venous sinus thrombosis, which is extremely uncommon condition to walk into your OPD, but just a due diligence of not ignoring that disc edema, even though patient said that, no, my headache is not severe. I hardly have it a few times a week, and maybe it's due to my work stress only, but just that small due diligence of not ignoring the disc edema, I found this interesting condition, which is actually a medical emergency. The clot will just keep expanding and it can actually even be fatal. And this patient needed blood thinners, and I made sure that by the end of the day, he was already on heparin to break the clot in the brain. Third patient, another small 11-year-old female, headache, intermittent double vision. Another third sign that we had discussed was double vision, again not to be ignored. There's hardly any esotropia if you look at the primary case, but the moment you look at her extreme gazes, you see there is a definitely left eye abduction limitation. And when I did a cover test, there was definitely a 15 prism base out deviation in the primary gaze. Imaging done, and there we see there is some lesion which has undergone hemorrhage. It was a cerebral cavernous venous malformation, something which had developed a hemorrhage recently. And because of that, this patient had developed with this sixth nerve paralysis of the left eye. Again, a small due diligence, double vision, never to be ignored along with the headache. Another patient walked in with migraine kind of treatment being given by an RMP, but again, a middle-aged male with headache with no other symptoms like photophobia, phonophobia, and males generally don't have that commonly present with migraine. So he had been managed for the past 5-6 months by an RMP, and then he said suddenly that something near the nose is getting fuzzy, like it's not very clear. Again, red flag, some visual field changes there. I did the visual field and as you can see, definitely left inferior nasal scotoma is there. I picked it up, ordered the neuroimaging, and there it is, one sphenoorbital meningioma sitting in the brain, probably growing for a couple of months. And finally, we were able to pick it up and refer to the neurosurgeon. This is a case which is very close to me because personally, I feel that most of such patients go on without treatment, and by the time we get to know, it's already too late. So she had been having a one-sided temporal headache for a couple of months with, some jaw claudication kind of symptoms also. She said there is pain while eating, and her dentist told her that she had to undergo a root canal. She underwent the procedure. There was hardly any relief. She went to another ophthalmologist. They said, let's do a cataract surgery, although cataract and pain have absolutely no correlation. She went for the cataract surgery. 3 days after the cataract surgery, there was loss of vision. It was PL positive. Hardly any vision was there in that eye. And look at the fundus. This is a case of very clear case of pallid disc edema, which is an arteritic ischemic optic neuropathy. So could we have picked it up? Most of these patients present like this, and we rush to give them IV steroids so that the next, the left eye will not get involved. We've already lost the one eye. But her symptoms, along with headache, she had weight loss, everything was there. So when I looked at her closely, just look at this. This rod-like thickening of the temporal artery. I palpated it, it was extremely hard, completely like a rod. And she had been visiting multiple doctors, from doctor to doctor she had been going. And this thing, she said, I told them also that something has become very hard in this area and there is pain in this area only. Look at the ESR. It was 56, CRP 35.18. We could have probably picked it up like maybe 6 to 7 months ago when she started complaining of her symptoms. But no, we had to wait. We had to pick it up only after one eye vision was lost. So even though this is not a common presentation in your OPD, but if you see such kind of a patient complaining of temporal headache, some jaw claudication, some weight loss, and this kind of a temporal prominent arteries, I would really give it a thought about thinking about giant cell arteritis, especially when the age is in the 70 to 80-year-old bracket. Now we come to the next abnormal finding we see in our OPD, the pupil. So first of all, some very normal pupils get labeled as abnormal. So this is a pupil which is called as a breathing pupil. It is symmetrically contracting, dilating, irrespective of the changes in the light. So this is called as pupillary hippus, which is rhythmic, involuntary, and irrespective of the light changes. So first, this is to be clarified because this is not an abnormal pupil and it gets labeled as abnormal very often. Now, how to go about evaluating the pupil? Simple protocol to be followed. First, you look at both the pupils. Are they equal? Are they round? Are they reactive? And then we should go to the light response and the accommodation response instead of going reverse, where we start from the light response and then lastly, we look at whether they are reactive and whether they are round or not. Again, how to go about it? First, you shine the torch near the base of the nose instead of directly into the eyes of the patient, and then look at both the pupils if they're round and reactive. Then, when you're looking at the pupillary response, there are 3 prerequisites which should always be kept in mind. One is that the light should be dim to dark. Second, they should be looking at a distant target. This is another important thing that we often forget. We just immediately take our torch and go and directly flash it in the eye of the patient, and the patient is looking at the torch, and what you are seeing is the accommodation response in addition, the accommodation response in addition to the light response. So you can't really tell the difference. So you should always make sure that the patient is looking at a distant target and then start your looking for the light response and the swinging light test. So now, once you've seen this, once you have done the basic evaluation, now when you want to diagnose, what is the problem with the pupil? 2 divisions you make there and then only. Is there a problem with the size of the pupil? Anisocoria, like one pupil is small and one pupil is large. If that is the problem, that's a completely different system. Then you're dealing with the sympathetic and parasympathetic, which is the efferent system. If the pupil ka response to light or accommodation is dysfunctional, then you think of the afferent system. So first division will be made here only. If it is an afferent or an afferent pupillary defect or a relative afferent pupillary defect, then you look at the optic nerve and the retina and the afferent pathway of the system. But if there is a defect in the efferent pathway, then you compare the pupils in the light and the dark. If the difference in the sizes of the pupil gets worse in the dark, you look at the sympathetic pathway and you think about Horner syndrome and those other conditions. If this difference becomes worse in the bright light, then you think of the parasympathetic pathway or the third nerve. Now let's look at a few examples of this as well. This is an image I've taken from the internet, unfortunately. So this is a patient which is very commonly presenting in our OPDs, neuro-ophthalmology OPDs, where they present with a suddenly just one complaint that one of my pupil definitely looks bigger. And they have no other complaint. There's no headache, there's no nerve paralysis, nothing is there. And when you look at it, the anisocoria gets worse when the patient is in the bright light. I didn't quite catch that. Sorry. So the anisocoria is much worse in the bright light. So when you see that, you're dealing with the parasympathetic pathway. Then you look at the accommodation response. So patient has poor response to bright light, and the patient also has a poor response to accommodation. And other than that, there will be no symptoms. There are no signs of the third nerve involvement at all. These are the patients of AD's tonic pupil. In addition to that, sometimes they also complain that there is some difficulty when they're looking at near objects. Some accommodation difficulties might be additionally present. Very common diagnosis, very easy to diagnose. What you have to do is you have to put 0.1% pilocarpine. Because there is a denervation hypersensitivity, the pupil will immediately constrict, and there and then you have your diagnosis of AD's tonic pupil. So, but then it looks complicated. 0.1% pilocarpine, we don't really have that in our OPD, right? So you pick up a bottle of pilocarpine, you take, it is 1% in the pharmacy, you take 1.25 ml of it, you take it in a syringe of 1 ml, and rest of it you put with normal saline. After you dilute it, you get your 0.1% pilocarpine, and you can put it in the patient's eye, and immediately there will be a constriction of the pupil after some time, and that will give you your diagnosis of AD's tonic pupil. Very simple to manage. You have to first get a general physician's consultation, because it can be a part of a Holmes AD's syndrome, where there have been reported, which are very rare obviously, but it can be Holmes AD syndrome where the other reflexes may also be diminished. That will need their assessment and evaluation. But if that is not the case, it's an isolated case of AD's tonic pupil, you just have to give them a diluted dose of pilocarpine, which they can put 2 to 3 times a day. And if they're having some accommodation issues, then you add the bifocal lenses along with it. This small patient walked into my OPD. The pupils are not nicely visible in this photograph, but she had ptosis, and I was about to dismiss her as a case of congenital ptosis. But then suddenly I noticed that the pupil sizes were definitely not normal. So this is the reference I'm giving you for what I actually saw. So there was some small amount of anisocoria, could be dismissed, could be physiological. The moment I put the patient in dim light, this anisocoria actually worsened. So now what am I dealing with? I'm dealing with ptosis. There is some amount of miosis, which is worsening in dim light, and possibility there is a case of enophthalmos as well. This was actually a case of Horner syndrome. And when I asked the patient's history and I looked at the previous photographs when the child was born, barely this child was 7 months old, definitely it was not there before. The parents were very particular, and then I saw the family album tomography thing, then they said that it was definitely this ptosis was not there. So when there is a congenital Horner syndrome, you can relax. There's not really much that you need to do. But if it is a case of acquired Horner syndrome, then you have to send the patient for an evaluation to rule out neuroblastoma. So the small tip in my OPD, just looking at the pupils and then comparing them in dim light and dark, I could pick up the patient of Horner syndrome. Another important pupillary condition that you guys need to be aware of is when you have it in association with third nerve palsy. So this is a simple down and out eye of a third nerve paralysis, and she looks fairly old. She had diabetes, she was a hypertensive, not really much to worry about, looks like a case of ischemic mononeuropathy till the time you look at the pupils. So right eye ka third nerve pupil is also involved. So what the dictum says is that majority of ischemic mononeuropathies will not have the pupil involved, up to 80% of them, because the pupillary fibers are sitting at the outside. And when you have an ischemic mononeuropathy, the nerve starts getting involved from the center to out. So basically your pupillary fibers will get spared unless there is something which is pressing from the outside. So these are the candidates which need imaging, which is urgent, which is either a CT angiography or an MR angiography to look for a posterior cerebral artery aneurysm that may be actually putting pressure on the third nerve. So this patient was evaluated. Luckily, she did not have anything of the sort. So even though in 20% of ischemic mononeuropathies, pupil can be involved, you have to do your due diligence. If you see the pupil involved in a third nerve palsy, it's better to do the neuroimaging. Now, the most commonly what you see is an RAPD. RAPD to diagnose is very easy. Like you just put the light in one eye, both constrict, you put in the other eye, the pupils are dilated. But interpretation is where things become challenging for most people. So what does the RAPD actually mean? RAPD means there is a unilateral defect in the afferent pathway. Afferent pathway, mainly we are dealing with up to the chiasma. Because after the chiasma, they mainly get the fibers cross over to when they reach the Edinger-Westphal nucleus. So mainly we are dealing with something in the prechiasmal region and the retina and the optic nerve in that region only. So this is where you should look for your defect. Then it can also mean that bilaterally the nerves are involved, but it is an unequal involvement. The eye showing RAPD is actually more damaged than the other nerve. These are the two interpretations which you can have when you look at RAPD. Causes can be optic neuritis, it can be a central retinal artery occlusion, ischemic optic neuropathies, compressive, traumatic. The list is just endless. The questions that come along with RAPD is, when there is an afferent defect in one eye, will the pupil size change baseline? And the answer for that is no. Even if you have one functioning normal nerve, it is going to provide bilateral stimulus to the Edinger-Westphal nucleus, and the pupil size will be normal in both the eyes. So can there be bilateral RAPD? This is a finding I've seen sometimes in OPD files, which is an incorrect statement. RAPD means one eye is damaged with respect to the other. Bilateral RAPD is not a correct terminology. It is a misnomer. Then there's another question. Can there be normal vision with RAPD? Now the answer to this question is yes. Very frequently, we have seen that patients come with 6/6 vision. Not very frequently, but we have seen patients who come with 6/6 vision and they have an IRPD. The next step that you're going to do is look at the color vision and the visual field. Optic neuritis patients initially present with sometimes just color desaturation or a visual field defect, and their vision may actually be even normal. So, vision means all three components. The Snell's vision acuity, you look at the color vision and you also look at the visual field. The last question that comes is, what if one of my pupils is damaged? Maybe there's been a case of uveitis, maybe there is a case of traumatic optic neuropathy, maybe there is a sphincter damage in that eye, the corneal edema is there. So can I check for RAPD when there is only one single functioning pupil? Can I check both the nerves with just one eye functional? So then the answer to that is yes. So this is the process how we go about it. Imagine the right eye has dense posterior synechiae. Some old uveitis has happened and we are left with only left optic nerve functional, left pupil functional. So can I check both the nerves? Definitely I can. So first I will flash my light into the left eye and I can see that the left pupil has constricted. Then I flash my light into the right pupil and then I look at the response of the left pupil. If the right eye is weaker, the nerve is damaged or has some traumatic optic neuropathy or any kind of damage, then the left eye will get a lesser consensual response in this case and the consensual reflex will be weaker. So when you look at it, actually when you're looking at it, when you put the torch on the left eye, the pupil constricted, but when you put it on the right eye, the pupil dilated. But actually what it means is that the consensual reflex is weaker than the direct reflex. This is called as reverse RAPD or inverse RAPD, which you can check in patients of specifically trauma cases. When there is difficult to assess one eye because of some hemorrhage, some corneal edema or some pupillary sphincter damages. Then going to the last topic that I'll be covering today, which is the visual field. This diagram is overused everywhere present, but significantly leaves out a lot of neuro-ophthalmological visual field defects. So I'll be covering those which this diagram does not cover. So let's see this patient, 27-year-old male with gradual diminution of vision. Hardly much vision loss is there, 6/9, 6/6 kind of vision, but color vision loss is definitely there. And you look at it, this is the right eye visual field. And you can see that the blind spot has coalesced with the central part of the visual field. And this is something where there is a central scotoma extending up to the blind spot that is called as centrocecal scotoma. Very commonly seen in our OPD, which actually signifies the damage to the papillomacular bundle, where the most of the significant fibers are there, which are rich in mitochondria as well. So mitochondrial diseases are quick to affect these fibers, and these patients will present with just a centrocecal scotoma. This was the fundus of this patient. Out of curiosity, just to mention that there was some mild tortuosity of the optic nerves and there was a disc pallor in the temporal part of the retina. So this is the papillomacular bundle running from the optic nerve to the fovea, and this is where the damage happens. And even though these fibers are very sensitive and they get damaged by even oxidative stress in conditions where people are chronic smokers or alcoholics or some certain toxic drugs, but this patient had something called as Leber's hereditary optic neuropathy. So these hereditary optic neuropathies present with a centrocecal scotoma because these are mitochondrial diseases and the mitochondria are most rich in the papillomacular bundle. The other causes, obviously, like we discussed, the tobacco, alcohol, amblyopia, the smoking cases, the nutritional deficiencies. And yes, even in optic neuritis, sometimes they may just present with a central scotoma. Now, this is a scotoma, which is basically just where the blind spot is there. It has just spread from there. If you look at it carefully, in the left eye, there is a blind spot and there is a scotoma, which is just abutting that. So what is this? Just look at the fundus, then you will understand that this is a case of a papilledema. So when the disc gets edematous, the fluid leaks out from the disc and it forms an enlargement of the absolute scotoma, which is present at the optic nerve. And that is called as an enlargement of the blind spot. And this is seen classically in patients which have disc edema. Then this patient, very commonly presenting in almost everyone's OPD, is some elderly female with diabetes or hypertension with sudden diminution of vision in the morning. And classically, sometimes they may give you a history that I woke up in the morning and 1/2 of my vision was lost. This patient actually also had cataract, so it would be wise to just go to the pattern deviation plot. And what you see is that the inferior half of the visual field is lost. Look at the disc opposite pole. Like if the inferior part of the disc of the visual field was lost, there was a superior hyperemia and superior disc edema. This is a very common case, inferior altitudinal defect caused by non-arthritic ischemic optic neuropathy, NAIN, which we call. So what happens basically in NAIN is that there are these short posterior ciliary arteries. Some are supplying the superior part of the retina, superior part of the optic nerve. Some are supplying the inferior part of the optic nerve. Classically, the hypothesis is given is that these patients will have a disc at risk, will be a small crowded disc. And when these patients who are a known hypertensive will have fluctuations in their blood pressure, like especially during the early morning hypotension period, suddenly there will be a spasm of these vessels and the blood supply will get compromised and they will present in the morning with that kind of a visual field defect. So how do we evaluate? Look for the vascular risk factors, hypertension, diabetes, high cholesterol, very common, everyone will check for it. What we don't ask for is a history of sleep apnea. Very common, majority of the males in our society will have history of snoring. So this is something which causes intermittent nocturnal hypoxia and hypotension in these patients, and snoring is also sometimes responsible for NAIN. Disc at risk, you look for in the other eye, it will be a small crowded disc. That's why the patient suffered from this condition. And another important factor that we forget to ask is for phosphodiesterase 5 inhibitors or the use of Viagra. Then this is another interesting patient, might not see in the OPD, but definitely even if you don't do the visual field, you will find a patient who will describe something like this to you. 17-year-old girl with headaches with this kind of a visual field defect. Very confusing, doesn't fit into any of the patterns that we have discussed so far. So what are we exactly dealing with? So I asked more on the history, that how it actually presents. Then she gave me this description, which is very classical, that this visual field scotoma will appear in her vision and it will slowly expand. That is when I realized what I'm dealing with. It was actually just a migraine aura or a scintillating scotoma. There was no brain issue, there was no eye issue. It was just a migraine aura and a scintillating scotoma. This is something we see very commonly, one side visual field defect. You know what we're dealing with. It's a homonymous hemianopia. How to localize? It's given right there. They have homonymous hemianopias. They've told you where the damage is, somewhere in the retrochiasmal pathway after the crossing over of fibers have occurred. Very easy to diagnose. This patient had a stroke. Simple to diagnose. Now, this is something gets a little bit more challenging. So you have a scotoma, which is respecting the vertical midline. Obviously, it is not glaucoma. It's a neuro-ophthalmological field defect, but they don't quite match each other. So what is this exactly? So this is something known as incongruous homonymous hemianopia. it is a retrochiasmal pathway damage. You have to localize it to the retrochiasma only because it respects the vertical midline. It's on the same side. But then why don't they look so similar to each other? For that, we need to understand what is congruous and what is incongruous visual field defects. So when we look at the visual pathway in 2D, it looks kind of like this. But when you look at in this 3D, at this particular retrochiasmal part of the pathway, it actually is like this. The fibers are spread out before they collect together again near the occipital cortex. So this was the retrochiasmal pathway as it looks like in 2 dimension. But when you look at it in the 3 dimension, this is actually how the fibers fan out. So if you have a lesion near the occipital cortex, then definitely you will get a very congruous visual field defect. But what if you have a lesion somewhere along the pathway? Then the fibers are actually fanning out and spreading out. Then there's a possibility you might not get visual field defects which are very similar to each other. And those are called as incongruous visual field defects. Thank you for your time. I think I was within time. I tried to cover a couple of points. We can discuss any questions and doubts if they're there.
Thank you, Dr. Asmita. This was a wonderful, very elaborate case presentation and highlighting different important aspects that what we all should follow in a routine OPD. I just wanted to even highlight this that we spoke about headaches. So headaches with history also we can make out as in what the patient is going through. So depending upon the onset duration, if there is any aura, rhinorrhea, photophobia, we can look at if there is any sinusitis, any dental pain, if you're dealing with primary headache disorders. Okay, so that way when ophthalmology examination is normal, our history will give us an idea. And of course, we can go ahead and, take an ENT review or a dental review. Like you have to rule out one condition after the other. Plus, you even highlighted, like in a case of where you had temporal arthritis, how fever, weight loss, malaise, this along with the severe vision loss, you need to investigate. So there are certain, what you call is we have certain low risk headaches and high risk headaches. There is a specific pointers which have been described, in certain papers. There is a question where someone wanted to know difference between congruous and incongruous scotoma. They just wanted you to explain it one more time.
Okay, so basically congruous and incongruous means that they are kind of like mirror images of each other. So as we saw in the case of the patient with the stroke, they just look exactly alike. And if you look at this diagram also, you see that this is describing a visual field defect where you see that the left and the right eye have very similar defects. They look exactly the same. And this one also is having a pie in the sky kind of a visual field defect. They look exactly the same. So this patient had a congruous visual field defect where they are looking completely the same. But that doesn't mean that these visual field defects don't exist, where if you look at this is looking like a bit exaggerated version of a quadrantianopia, and this is almost like a hemianopia. So they are respecting the vertical midline. They are on the same side of the vertical midline, but they're not exactly exact replica of each other. That is what is called as an incongruous visual field defect.
Thank you. Thank you for answering this. There is one more question. What is the role of color vision testing and visual field as a screening modality to pick up neuro-ophthalmology cases?
Okay, so it is very difficult to order perimetry and color vision defects for every patient. I wouldn't order it for every patient, but any patient with a neuro-ophthalmological disorder, like even if they're saying of a mild diminution of vision and you're looking at the optic nerve, it doesn't quite look healthy. There is some pallor in one corner or some fibers appear edematous. The moment you're dealing with neuro-ophthalmology and looking at the optic nerve as a cause of your condition, definitely I would not complete the examination till the time the visual field and color vision of the patient has been done. But not for every patient. I would really stick to the patients where I feel that the nerve is looking anomalous and I want to look for the cause of that anomaly. Then every time color vision and visual field defects have given me a clue as to what could be the cause. Even before the neuroimaging, perimetry has to be done for every patient with an optic nerve disorder.
Right. Thank you. Thank you. And sometimes with history, even if the vision loss is not very significant, we do need assistance with our field testing, our pupil examination, contrast, color vision. Sometimes we require VEP in order to understand if we're dealing with something subclinical. So basically, that's the kind of approach that we us neuro-ophthalmologists, we usually go about when we cannot justify as in why the vision is not improving
Yes.
beyond a certain point, when we know overall grossly not much of a pupillary defect can be seen or the disc appears to be normal, we need to understand. So that is when all these investigations come into play. I think you have given a beautiful background, because I think with my presentation, having this as a background, our audience will be able to understand as in my case, as in what I was dealing with or what was my thought process when I was approaching a specific case. Okay, so the title of my presentation today is When a Dilated Pupil Poses as an Uncommon Ophthalmic Emergency. Now, why did I choose this as a title? We will find out. So this is about a 53-year-old female who presented to a neuro-ophthalmology clinic. She came with sudden onset of severe throbbing type of headache, which was affecting mainly her right side of her face. And it was associated with peripheral progressive darkening of the vision. This was very typical that she complained of. And she did not have any vision issues in terms of she could see well, read well. There was no diplopia. There was no history of head trauma. There was no history of any fall, no fever, no weight loss that she was complaining of. Only history was that she had undergone cataract surgery 2 weeks ago. And this was the only significant history that she gave. Looking at her records, the cataract surgery was uneventful. On probing her medical history, when she was very young, she was a known case of migraine with auras, but auras used to be like scintillating auras. And she had taken medications for quite some time, but she had no episodes of migraine. She was migraine free for a couple of years. The only history in terms of medical history, she was not on any medication besides oral multivitamins and intravenous glutathione that she was taking under medical supervision for almost 2 years. So looking at her examination, as we all can see, her visual acuity unaided was 6.6 and 6. When I saw her, her pupils were normal size, normal shape, reacting to light. Her pressures were within normal range. It was 16, measured on eye care. Her anterior segment showed very well-centered multifocal IOL implants. And her fundus examination was also normal, 0.5 CDR, and her color vision was also documented to be normal, and her extraocular motility were full. So I just decided to get her to do her visual fields, and if we can see, there is some mild constriction of the peripheral vision affecting both eyes. Then I did her OCT, like just as a documentation. If there is something that I'm missing, it was all normal. Then I wanted to know what am I dealing with. And since she has a history of migraine, I was like, never neuroimaging has been done. I think this was the right step that I asked the patient to undergo MRI brain with orbit and an MRA, where there were some bilateral parieto-occipital evidence of chronic infarcts, and MRA showed diffuse narrowing of right internal carotid artery and left MC and mid-basilar artery. Also, along with the MRI, I got her overall blood investigation. So she was diagnosed to have iron deficiency anemia. However, she's intolerant to oral iron supplements. Then what next? I thought I was dealing with a primary headache disorder. So I went ahead and I spoke to a neurologist. I referred the patient to a neurologist, and she was put on combination of magnesium, riboflavin, along with amitriptyline. I followed up with the patient. The patient arrived to the clinic after 2 weeks with the headache frequency being reduced, the peripheral darkening, which had become very transient. But however, this was a new symptom. Now she has started to develop photophobia. So she would prefer to be indoors, switching off all the lights and do nothing. It was really affecting her quality of life. So I repeated her visual acuity, color vision testing, contrast sensitivity, fundus was all normal. I repeated the fields again. Again, there was a peripheral constriction of field. Then I happened to look at her pupil. At this visit, her right eye pupil showed like it was dilated. There were certain sectoral movements, but there was no light reaction. There was light near dissociation basically on clinical examination. So I just happened to do a diluted pilocarpine test with 0.125%, and it showed a positive response in the right eye. But before doing that, I went ahead and I did her pupillography. As we can see in mesopic condition, there's a difference between right and a left eye. Now, minded, she has a multifocal lens in the eye, plus with a dilated pupil. So this was triggering her in like this photophobia that she was complaining of. And if you can see post pilocarpine test, our mesopic pupil size has reduced. So what was I dealing with? Has the patient developed a tonic pupil after her cataract surgery? An isocoria has arrived after a cataract surgery, or it's one of the migraine episodes which has led to a benign mydriasis. So I went ahead and, did some literature search. Like if you can see the article here, where pupil diameter in migraine and tension headaches were, like it was studied, this was published in 1987. They compared mean pupillary diameter in patients having common migraine at the time of examination and with controls having no headache. It was noted that the pupillary size was on the smaller side. So it was attributed to maybe something to do with sympathetic pupillary deficit. And in the non-headache interval, the pupillary diameter did not show any difference. Then again, I went ahead and did more of literature. So this was a very interesting article which was published by Dr. Ruby. So she compared baseline pupil size in patients with the migraine and patients who had no headaches. No headaches. She used IOL Master 700 to measure the pupillary size, and it was noted that in general, patients with migraine had a pupillary size of a larger diameter as compared to the control subjects who had no headaches, right? Looking at the disability assessment, the more severe the headaches, the pupillary diameter was much more. Then there was one more article which was published by her where she had noticed in patients who had migraine with photophobia and an enlarged pupil, they did very well with diluted pilocarpine eye drops, which was given over a period of 3 months, twice a day. The severity of headache was very less. The episodes of migraines had become very infrequent. So this was just a part of, like, it was a carry forward of this study. Then I happened to see one more case report where an isocoria was seen as a benign episodic unilateral mydriasis in patients with migraine. Now, exact pathophysiology is not known. In general, it is said that migraine basically means that there is cerebral hyperexcitability and there is something to do with cerebral vascular hypoperfusion, which can have an effect because of prolonged vasospasm, which can have an effect on the parasympathetic pathway leading to this pupillary dilatation, right? So this was one aspect to it. Now, my second thing was that we are dealing with something to do with post-cataract. Has this anisocoria been documented, especially this dilatation after an uncomplicated cataract surgery? Yes, we have numerous studies which have been mentioned. Like this was a study which was done over a period of 10 years where only 7 cases were identified. 7 patients had developed atonic pupil. It was a completely uncomplicated surgery. There were 5 patients who had undergone a scleral tunnel cataract surgery, cataract extraction, and 2 of them had clear cornea. Most of them had a retrobulbar block, which was given. And they did recognize that after 2 or 3 weeks of cataract surgery, this tonic pupil was identified. However, exact cause, nobody could identify. Several hypotheses were were identified in terms of it could be intraoperative increased intraocular pressure. It could be probably our retrobulbar anesthesia. It could be some OVDs that we are using, because there was one article where because of the molecular weight of OVD, it was stated that probably that has led to some iris sphincter ischemia. because of some mechanical compression. So this was one report. Then there was another report where, like as you can see, by Larson et al., where anisocoria developed following an uncomplicated cataract surgery. It was in a 69-year-old white female where no intraoperative pupil expansion devices were used, no floppy iris or iris prolapse was identified. Everybody on day one, post-operative day one, was all okay. And most of the time, it was within first month of the surgery that they all presented with intolerance to light. So again, this was thought probably it has something to do with parasympathetic dysfunction, which happens during cataract surgery. This is one thing which I wanted to highlight. There was one more article which was published where they wanted to understand and determine and compare the incidence of atonic pupil in modern extracapsular cataract extraction and small incision phacoemulsification. So this was published in 1995. Based on this study, it was concluded that the incidence of atonic pupil must be it is usually less in phacoemulsification as compared to the earlier extracapsular cataract extraction. Now, my patient had a field effect, so I wanted to understand that what is it in migraine that is inducing this peripheral constriction of field. So this was very interesting article that I could find out that visual field losses in patients with migraine without aura and tension type of headaches. Now, tension type of headaches and migraine, they all come in one category. Okay, it is all like a primary headache disorders. Now, depending upon the symptomatology, we classify them as migraine or tension type of headache, right? So this study basically aimed at understanding that during the pain attacks, what was the visual fields that were seen in two groups. So they had taken around 25 patients in both the groups, right? In both the groups, females were known to be affected. As we can see, the types of visual field effects, the most common that was seen was peripheral constriction of field and a peripheral island. So peripheral constricted field was seen in both, that is migraine patients and tension type of headache patients. Then we had if you can see here, nasal stepping was also seen in the migraine group, whereas altitudinal defects were hardly seen. So as we were discussing that the etiology basically means that probably it is something to do with hypoperfusion, prolonged vasospasm, release of microemboli, which can lead to these headaches. It was also seen that in patients with chronic migraine or with severe migraine, what do we see is reduced peripapillary RNFL thickness and choroidal thickness. And there has been a frequent association of migraine with normal tension glaucoma and ischemic optic neuropathy. Migraine is known to cause field losses, which is similar to glaucoma, or it could be one of the factors which is leading our glaucoma field losses to progress much more when we are dealing with normal tension glaucoma. And it was also seen that once you have an episode of migraine, the field effect might last up to 75 days. So this was also highlighted. And the more severe, more frequent if migraine is, or we have associated aura, the field losses will be much worse. So my patient currently is on diluted pilocarpine eye drops. It's been 2 months. She's been doing well. I think when she comes back for a follow-up, I'm going to repeat her visual field testing, and I will even give her like a free period. I want to make her off, wean her off diluted pilocarpine, just to see if her sphincter pupillae is again reacting to light, and then take a call as in if I need to continue, she's still symptomatic. Thank you very much. I hope this part has already been covered by Dr. Asmita. Thank you for your patient listening. If you have any questions, probably we can take them.
Till what stage can we treat myasthenia patients?
Myasthenia, now general myasthenia is usually treated by neurologists. Once we have an ocular myasthenia, we see the gravity of it. Of course, I do send it to a neurologist, basically just to see if there is no progression or we are not missing out to OMG turning into a progressive myasthenia. Usually ocular myasthenia, neuro-ophthalmologist treat it. If it's not responding to your treatment, then I refer it to a neurologist. And you can also share your inputs, Dr. Asmita.
Yes, I completely agree with you. After that, and sometimes even before I have to send because of the repetitive nerve stimulation testing and the the testing and neostigmine testing. But yeah, after if it is only ocular, then I might treat it orally with pyridostigmine only after the consultation with the neurologist. But if there are some general,
Signs, yeah.
signs, yeah, then I would refer it to a neurologist.
Usually neurostigmine, I conducted myself, okay, provided
Oh,
I
okay.
have ruled out general, it affecting any other body part. And I usually start them on low, some steroids in combination with pyridostigmine. And I tend to wean them off on second week from on steroids from the second week. If there is what you call a relapse after I've reduced the steroids, then probably I will definitely need a neurologist to, intervene and probably guide me as in what else can we do for the patient. So this is my usual approach, and yes.
Okay, so there's another question. Can we use alpha-GIN drops instead of pilocarpine drops?
Alpha-GIN drops, yeah, alpha-GIN to use 3 times, but see, I think here the pupillary enlargement was quite a bit. I don't have a lot of experience with alpha-GIN drops causing significant pupillary constriction. 3 times a day over, I think, a period of 6 to 8 weeks, I have seen
Yeah.
some amount of constriction, but we need to understand my patient had a multifocal IOL implantation. We do require, pupils to show a faster response, and I think diluted
Yes.
pilocarpine works wonderfully well. So, I was highlighting it in my presentation that Dr. Ruby is doing she is studying in migraine patients the response of diluted pilocarpine. She is using pupillometry to assess. So I think we will be knowing about this much more.
So is there a need for all migraine patients to undergo visual field assessment?
So I feel if they are complaining of peripheral field constriction, then yes. And if you have any signs of ocular hypertension or a compromised disc to begin with, or a physiological disc, then I feel yes, you should. And migraine is a diagnosis of exclusion. Let's not forget this, right? So we need to rule out every possible cause first. So perimetry becomes extremely important.
And there's another question. How often would you control visual field in migraine patients? Visual
How
field defects, I think they probably mean. How often would you control the visual field? I think they mean the visual field defect by the migraine patient.
So see, I did it at the time of presentation, then 2 weeks of follow-up. Now, usually it should be at the time of presentation, then probably at a month's interval and 3 months interval. That is how I follow, or maybe then after 3 months, 6 months. That is how I think I would follow up if I have to see a visual field in the migraine patients. If they are asymptomatic and I've weaned them off, probably I'll see them as a follow-up just to make sure that there are no symptoms which are coming back. The pupil is, not dilated. There is no evidence of any tonic pupil, and probably not get a visual field done at that moment.
Okay. There's one more question. How can we evaluate if patients present with only ptosis suddenly with no extraocular movement abnormality or other symptoms? Should we suggest neuroimaging?
Sudden onset ptosis. So sudden onset ptosis also you need to ask history of trauma, variation, diurnal variation. You need to do fatigue test. You need to find out other eye there is any lid lag, thyroid disorders, anything significant in terms of neurology point of view. Do an ice pack test, do a fatigue test, look at the pupil. Okay, complete the examination and then take a call. As in, if extraocular, yeah, subtle extraocular motility movements restrictions can be missed, so you have to be very careful. And except for ear infection, myasthenia patients usually if it's just sudden onset of ptosis fitting into a certain age group without any headache, no fever, or there is a history of fever which led to this along with diplopia, I think we should do all these clinical testing, send them for ACH receptor antibodies, do a RNS study, take a call. If everything comes out to be normal, then probably yes, then we would be doing neuroimaging. Dr. Asmita, you can also give me your input on this.
I agree with you. I have seen, and this has actually been one of my patients. This extraocular movement abnormality is sometimes very subtle. So there was a patient of ptosis and advised surgery also actually outside somewhere, and they picked up this mild elevation deficit, and he had a huge meningioma in the brain. So extraocular movement abnormalities can be sometimes very subtle, and like you also said, like we have to ask all the relevant history first. Traumatic ptosis, sometimes not even trauma. There's a condition called as blepharochalasis when
Correct.
see in young females that the lid gets swollen. So you ask for a history. Was there a swelling before? Even if it's not blepharochalasis and swelling, sometimes even after insect bite, when there is a lot of swelling in the lid, the LPS gets damaged somehow, and then you
Right.
can have some kind of ptosis. So young patients may, yeah, these causes I would rule out, and definitely myasthenia is the biggest mimicker. So always has to be ruled out with an ice pack, with a fatigue test, sneak test. Multiple tests are given online, and after all of that has been ruled out, then probably if I cannot explain it, obviously I'll get help from my oculoplasty colleagues, but yeah, then probably I might think of neuroimaging, because usually the fibers for the superior rectus and LPS kind of originate together. So finding an isolated ptosis without superior rectus involvement, third nerve, is not really the first diagnosis on my mind. I'll think of other things before. So, and ma'am has asked about dilution of pilocarpine. Ma'am, actually, it was. But I'll just repeat once more. It was there in my slide, but you just take a 1 ml, 1% pilocarpine bottle that you take 1.25 ml of it in a 1 ml syringe, and then the rest of the syringe in the rest of 9 ml, you'll just put 8.75 ml, you'll just put the normal saline. So you have 1.25 in dilated up to 10 times. So then you will get somewhere around 0.125. Just take one pilocarpine bottle, take 1.25 in a syringe of 10 ml, and then rest of it, you just put the normal saline. Then you can get close to 0.125.
What I follow is I take 2% of pilocarpine, take 1 ml of it,
Yes, yes, yeah.
dilute it with 1 ml of distilled water, right? Then I take 1 ml of that solution, dilute it again. Okay, I do 4 dilutions. From 2, it will become 1. From 1, it will become 0.5. From 0.5, it will become 0.25. From 0.25, it will become 0.125. So this is all I like. This is the way I've been doing during my fellowship days. So 2%, you take 1 ml of 2% of pilocarpine, mix it with 1 ml of distilled water. Now you take 1 ml of that solution and mix it with 1 ml of distilled water. So
Makes
you need
sense.
to, yes.
Serial dilutions till you get 0.125.
That depends upon the concentration of pilocarpine, yes.
That you have available in your pharmacy.
Yes,
Correct,
yes,
correct. Okay,
yes.
noted.
So this is what we do. And Dr. Asmita, you had mentioned about improving near vision in atonic pupil.
Yeah.
So there is a question of atonic pupil, how to improve the near vision if there is a complaint of.
So yes, we have seen that there are some patients with accommodation issues. I've treated them with by giving them bifocals temporarily, because most of these AD stonic people will recover over a period of time. And sometimes because only one eye is having accommodation issues, they may not really complain. But if the patient is complaining, I've managed them with bifocals. And I have to follow them up. But usually over 2 to 3 months, the tonicity will improve, and convergence and the accommodation and the pupil reactions will return back to normal. That is the most common course we see in patients of AD stonic pupil.
That is correct. Yes, that's the way you're supposed to, because it's a self-resolving. We are suspecting ganglionitis mostly, which is not like there is no proper cause of it.
Viral infections, post-viral infections, basically, we see.
Infections. Yes, yes, yes. So there is one more, like in addition to that, can we give progressive glasses or only bifocal?
Progressive glasses, never tried. Have you tried giving progressive glasses to these
No,
patients?
no. Usually the patients I've dealt with, they always had financial constraints. So bifocal being a cheaper option, they have been happy with bifocal glasses. And since it's temporary,
Yeah,
yes, so they do well with the bifocal glasses.
And even when the recovery happens, sometimes we have something called as little old daddies. The
Right.
pupil response, pupil may become very constricted, but accommodation usually returns to normal. Like even the accommodation fibers go to the pupil response and the pupil becomes tiny, small, constricted, but accommodation usually does return. So I've not seen patients where the accommodation has never returned after the attack of AD tonic.
So I think the highlight of today's webinar was please check your pupils. That is very important. Even if you're planning your cataract surgery, if your pupil baseline is on the higher side, like, in general, if a patient is a myope, see if on a topo or whatever investigating modalities you have, if you can document one pupillary diameter and then take a call as in which lens would you want to go ahead with.
Okay, ma'am has mentioned that because cosmetically one eye bifocal looks abnormal. So maybe we can try, ma'am, and I think I can get back on that. But for 2 to 3 months, if anybody would be willing to buy, but maybe we can try it out and then we can have a feedback on that, whether progressives were acceptable to these patients or not.
Yeah, thank you so much,
Yeah.
Dr. and Dr. Sakshi. It was wonderful. Due to some issue, I was not able to join the initial part, but I'm sure I'll go through it when I get the recorded link. A couple of them have asked whether we'll give the recorded link. Those who have registered for this webinar, all of this will be sent the record of the presentation. It was a wonderful presentation by Dr. Asmita and Dr. Sakshi, and thank you for moderating it so well as well.
Thank
Thank you so much.
Thank you, ma'am.
Have a lovely evening, everyone.
Thank you. Bye-bye.
Bye.
Thank you so much.
Thank you, doctors.
Thank you.